Hello, I'm Jan Leifman.
Hi, I'm Gayatri from Menon.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Avindra Nath. Dr. Nath currently serves as the chief of the section for infections of the nervous system at the NIH. He's also the clinical director of the National Institute of Neurological Disorders and Stroke.
In today's presentation, Dr. Nath discusses the effects of COVID-19 on the brain.
Did you know that Dr. Nath has been an invited international expert for every major outbreak, including Ebola, Zika, and SARS-CoV-2? He's a recipient of numerous national and international awards, including the NIH Directors Award and the Pioneer Award from the International Society of Neurovirology. He's also a recipient of over 7 patents and served on the World Health Organization Committee on Guillain Barré Syndrome with Zika virus infection.
He's such an inspiring pioneer in the field of neurology and virology.
So let's tune in. Let's tune in and learn from this global leader.
So I want to start with this quote by Sir William Osler. He is considered the father of modern medicine. And so just the way that we practice medicine, the way we examine patients, we take history, how we develop a differential diagnosis, all those principles were really established by him. And in the 1800s, he was the chair of internal medicine at Johns Hopkins University. And at that time, in 1896, he addressed the American Medical Association as the keynote speaker. And at that time, he said that humanity has but 3 great enemies: fever, famine, and war. And of these, by far the greatest, by far the most terrible is fever. And that actually holds true even today. What he means by fever is actually infections, and that infections have really killed more people on this planet than everything else put together. And if you look at the evolution of humans, you will see that one wave of infection would come, wipe out a huge population on the planet, few remain, they repopulate, then came another wave of infection, and so on and so forth. Okay. And the current infection is a reminder of that phenomenon. So not too long ago, you have the AIDS pandemic, and AIDS is still here. It hasn't quite disappeared. It was a new infection introduced into humans, and but it killed a lot of people, right? And so, as you can see, when that kind of devastation takes place, there's a lot of social unrest, and that happened during that time. And in fact, if you look at the, this is a picture of the Washington Mall. The Capitol building is right there. And you can see what is called the AIDS quilt. So every year, the AIDS quilt will be put out there. And every piece of fabric represented an individual who had died of AIDS. Eventually, the quilt became so huge that it could no longer fit on the mall itself. You fast forward 40 years later, and what you see is the same Washington Mall, but this time what you have is flags. And these are 440,000 flags that were planted at the time of the inauguration of a current president, representing each individual who died of COVID. Okay. And now, a year and a half or 2 years into it, what you see is that over 1 million people have died. So 1 million is just the official numbers for the United States, but we all know that a lot more people died than the official numbers. And at the peak of it, there were about 4,000 people dying per day. Okay. And even now, 300 to 400 people are dying every day. That's 10 times more than would ever die from a flu infection. And the total number of 1 million exceeds the number of people who have in total died of AIDS in the United States. Globally, we don't actually know the numbers, but the WHO estimates that at least 50 million have died. So in today's era, you lose that many number of individuals to a single infection is just unbelievable. Okay, absolutely unbelievable. So a lot of you had never heard of the word coronavirus, but coronaviruses have been around for a long time. And there are at least 8 human coronaviruses. So there are lots and lots of coronaviruses that live in bats and such, but there are 8 that have jumped into humans. The interesting thing is that each one of them has been associated with neurological complications. Okay, so SARS-CoV-2 is not the only one that causes neurological complications, but this is a phenomenon associated with all of these viruses. The thing is that most often the neurological complications are underappreciated. Usually people focus on the actual initial infection that takes place, and they don't think of the possibility that the brain might be affected as well. And that's been true with every pandemic. With the HIV, it was the same thing. People were complaining of cognitive problems, and most people just ignored them. They were more focused on the immune deficiency. So, but anyways, then if you look at the SARS-CoV-2 further, you can divide them into all these different variants. And I'm sure you've heard of each one of them in the news. And currently we are in the midst of the Omicron, and it is the BA.2, and now there are subtypes of the BA.2 that are also prevalent now. And South Africa is already reporting the BA.3, 4, and 5, so they are on their way. The interesting thing about each one of them is that they all cause neurological complications, and the complications are quite similar between all of them. The only difference is that by the time Omicron came around, a large amount of the population has either been vaccinated or have prior immunity from infections. So we haven't seen the same amount of a volume of acute neurological problems as we had seen with the previous ones. What has also happened is that each variant has become more and more transmissible. So a new variant has to compete out the previous one in order to survive. So it has to be more transmissible. The interesting thing is that these variants continue to circulate while the previous ones that I showed you, for example, MERS and SARS-CoV-1, they just naturally dissipated. And the reason they naturally dissipated is that those variants had a deletion mutation in them. So they lost close to 200 base pairs of nucleic acid was lost from it, which made them less virulent, but yet more infectious. So it was as though they became like a live vaccine of sorts. And so the population got immunized and the infection disappeared. We were hoping the same thing would happen with SARS-CoV-2, but actually this hasn't happened as of yet. Its virulence hasn't changed, and its infectivity has actually gone up. Okay, so what are the neurological complications? As I said, that and they are still fairly under-recognized. A lot of people will go to physicians complaining of various neurological manifestations, and many physicians don't really know what to do about it, or don't even know whether they are real or not, right? So the objective evidence for these things has been very hard to document. But the neurological manifestations can occur at every single stage of this infection. So you can have it during the acute stage, and during the acute stage, these patients are admitted to the hospital. So there, it's no surprise that, if the lungs are affected or the kidneys are affected or the heart gets involved, the brain will be a secondary bystander, and there'll be lack of oxygen or other kinds of metabolic abnormalities that can affect the brain. So that is understandable. However, there are some direct things that can happen with the COVID, and one is strokes. There are a wide variety of strokes that can occur, and I'll discuss that in a little bit more detail. Viral encephalitis is actually pretty rare. We thought for sure we're going to find virus in the brain, and to our surprise, it's been very rarely demonstrated. And even the spinal fluid, you can't really find it there. So it's quite strange that you have a lot of neurological problems, but yet, you can't really demonstrate the virus. And then there's this very strange syndrome called sudden death, or Ondine's curse. Okay, so Ondine was a princess who had cast a spell on her ex-husband, and it's a fairy tale, but nonetheless, it is what we use in medical terms to describe sudden death when it's due to effects on the brain. So in the subacute stage, there are a number of inflammatory syndromes, and these are quite common with most infections. So it's nothing specific for SARS, but except this last one, which is called the multisystem inflammatory syndrome. And I'll discuss that a little bit in detail because it occurs in children, really in adults. And lastly, I'm going to spend most of the time talking about the chronic manifestation, which is long COVID, because you have millions and millions of people affected by it. Okay, so one central theme here in all of these is that the SARS-CoV-2 virus has an affinity for blood vessels. And the reason for that is there's a molecule called ACE2, or angiotensin converting enzyme 2, that is present on the surface of the endothelial cells. Those are the cells that line the blood vessels. And this virus will attach to that. The spike protein will attach to it. And by doing so, it can either infect those cells or cause all kinds of derangement of the vasculature. So a lot of the manifestations are due to abnormalities in the blood vessels, and I want to share some of that with you. Okay. So here are 3 different patients, all infected with COVID. The first one presents with clotting of the arteries. So this dark area over here is a stroke. There is lack of blood supply to this area. And so this is the left side of the brain. So, it's a mirror image. And then you have on the right side, again, you can see this area that's kind of dark. So this patient actually had occlusion of blood vessels on both sides of the brain. Okay, that's very, very unusual. Usually when people have strokes, they'll have it only on one side, but not on both sides at the same time. But that is an interesting observation with COVID. The second patient has a totally different disease with COVID. All these dark spots over here, you see these small dark spots, these are actually blood. So on an MRI scan, the blood appears black because of iron present there. So these are microbleeds. You can see these small, small bleeds all throughout the brain, right? So that's the second type of presentation. And then this third presentation is a clotting of the venular system. So the veins in the brain here are called this is called the sagittal sinus. And you can see this white kind of pattern here. That's because the blood is clotted over here. Okay. So you can get any of these 3 different types of manifestations due to the same infection. Each one of them has to be treated very, very different. Okay. So that's why recognizing the pattern of infection is absolutely critical. Okay. The other thing is that we always think that the first symptom that's going to occur is loss of smell or respiratory infections, and all these other complications must occur secondarily. That's actually not true. So this elegant piece of work shows that here's the line at 0. They drew this line at 0. Okay, and so you have these days of onset. 0 is when you have respiratory symptoms, and then if you go above, that's like up to 120 days after the onset of respiratory symptoms. Or you can go before the onset of respiratory symptoms. So they go up to 10 days here. So the interesting thing in the data is really at the bottom. And what it is that all these things, strokes, inflammation, delirium, psychiatric manifestations, neuropathies, in some individuals can occur almost 5 to 10 days before the onset of the respiratory symptoms. So one may show up at the doctor's place and say, with a stroke or anxiety or depression or psychosis, and the doctor may not realize that this could be due to COVID because you don't have any of the other symptoms. And it may be days later that the other symptoms of COVID may actually show up. Okay, so we looked at some brain tissues here, and these brain tissues we got from Dr. Folkert, who is the medical examiner in New York. And in the early part of the pandemic, it was a really a remarkable time when lots of people were dying and nobody quite understood what was really happening. So I knew from my past experience with the previous pandemics that neurological complications are going to be prominent front and center, but the only way people are going to believe me is that I need to look at the brain tissue, convince myself and others that the virus is or is not doing something to the brain, right? And so I thought, okay, if I can demonstrate the virus in the brain, then everybody will believe, yes, it's doing something. But the problem was that at that time, PPE was not available, vacuum saws were not available. Nobody was doing autopsies. You would think in the United States, you could probably do an autopsy in an individual who has a respiratory infection of some sort. We would be able to take all precautions and do it. But the answer was no. We wrote to a lot of pathologists around the country, and most people said either they didn't have a vacuum saw, or they didn't have the PPE, or they didn't have a negative pressure room. Something was missing. They were willing to do it. It's just that they didn't have the proper equipment to do it. So when I talked to the medical examiner, she said that, well, we are also not doing it. If a patient tests COVID positive, they go in a refrigerated truck, and they had hundreds of patients sitting in these refrigerated trucks. It was a terrible situation at that time. But what they didn't realize is that they had already done autopsies on patients with COVID, because they didn't realize that there was a pandemic brewing in the city of New York. And so we were able to get tissues to look at from them. And so here you can see that there are these congested blood vessels here. And here's a microhemorrhage in the cerebellum, right? And then I'll show you much more details of histologically exactly what these things represent. But another factor that I want to tell you, not everybody develops it, right? So who are these people who are developing it and why? We don't know all the answers, but this is an interesting study. And what they claimed is that those individuals who have this gene called ApoE4, okay, this is a gene that's been associated with cardiovascular disease and also with Alzheimer's. So if you have it, you should blame your parents. Those individuals who have this gene also are at greater risk of developing hemorrhages within the brain, more hemorrhages and larger size hemorrhages, if they develop COVID. Okay, so when we got the brains from New York, what we did was we said that, okay, I don't know where to look for this pathology. So what we would like to do is do an MRI scan of the brain first. Now, I knew that by the regular MRI scanners, you're not going to see anything. So what we need is very high resolution MRI scanners. So one good thing we have at NIH is we have some of the highest resolution MRI scanners that anybody has in the world. Right? But under normal times, I would never be able to access it because there are people who have them are doing their own research, and the last thing they want is somebody else to be putting their brains in there. But during COVID times, interestingly, the only people who were allowed to enter the building were those who were doing COVID research. So all these other researchers were sitting at home. And so I contacted them and said, listen, we have these COVID brains, can we put it through your scanner? And they were absolutely delighted to help because that allowed them to get out of their house as well. And but they were very generous. I mean, they came and put it through the scanner and took very fine sections through the entire brain. Okay? And so what I'm showing you here is the brainstem, part of the brainstem. And this yellow circle is around the blood vessels here. Okay. And then under higher resolution, this blood vessel has 3 different types of pathologies, okay, which is very, very fascinating. I've never seen it with any other disease before. So this wall of the blood vessel appears, hyper intense, this kind of whitish over here. That tells you there's something abnormal about this wall. Inside this blood vessel is this little clot, this whitish clot sitting over there. So you have a blood clot in the blood vessel, and the wall of the blood vessel is abnormal. Now they cut the same blood vessel in a different plane. And now you can see this dark stuff over here, which is blood, right? So this is a microhemorrhage. So you have 3 different pathologies in the same blood vessel of a single individual. So that tells you the complexity of how to treat these people, right? Because each pathology needs to be treated differently, but it's hard because if you want to prevent the bleeding, you're going to end up causing more blood clots. If you prevent the blood clots, you're going to cause more bleeding. So that becomes a real dilemma as to what to do with these individuals. Okay, there are 2 other manifestations which are really bizarre, but I think we're trying to get a handle on it. So one is ringing of the ears. A number of patients were complaining about ringing in their ears. Okay, and so here in this study, you can see almost 23% or so of individuals had different various types of ringing in their ears, and some also had this dizziness, but the dizziness is one that could be localized to the internal and the inner ear. So the ringing in the ears, the dizziness, and also some decreased hearing, all localized to the inner ear. And this happens very acutely in these patients. They're fine, and then all of a sudden, boom. So most likely, what I think is that it's a small stroke in the inner ear that is causing these symptoms. Okay, there's a small blood vessel that goes to the inner ear called the cochlear artery, and it's quite possible that there is an occlusion there that's doing it. It's very hard to see on an MRI scan. Okay, so now I'm going to move into the second type of thing, which we call subacute inflammation. So this occurs a few days after the onset of infection, and that's why we call it subacute. And I'll give you a few examples of these. As I told you that they can occur with other types of infections as well. So this is a phenomenon that has a long name. It's called acute, and that's called disseminated. That means it's present in multiple areas within the brain and spinal cord. Encephalomyelitis. Encephalo means brain, and myelitis means spinal cord, right? So you can see this ring-like appearance over here. There's another, this nodule like over here where the arrows are pointing to. So those are areas of inflammation within the brain. Okay. And this is an area of inflammation within the spinal cord, the spindle-form kind of a lesion here. Now, recognizing that is important because what we know from other diseases is that the types of cells that cause this inflammation are very distinct, and we call them T cells. So they're largely T cells that infiltrate here. So if you were to treat these patients, you would use those kinds of drugs that would block these T cells. Okay. And this is another MRI scan, which is reported in the literature. And this was a person who lived in Detroit, and she was working for Delta Airlines at that time. I think it was Delta, yeah, because Detroit has a hub for Delta. So she developed these acute manifestations. And when they looked at the brain here, you can see this lesion here in the thalamus of the brain, right in the center of the brain. Okay, and there's bleeding in it, but it's very symmetrical on both sides. And so because there's bleeding associated with it, and it's very characteristic involvement of the thalamus, it is called acute necrotizing because causing necrosis leading to bleeding, hemorrhagic in blood, and encephalopathy. So it's not the same type of inflammation that you see with T cells here. That's why this is called itis, encephalomyelitis. This is called encephalopathy because they're not the cells that are driving it, but rather it is mediated by cytokines. And that's important to recognize because the treatment would be directed against the cytokines instead. Okay, now I told you that this is an interesting manifestation that is unique to COVID, and it affects children. And it's called multi-system inflammatory syndrome with COVID. And it can be quite devastating, and children can die from it. A lot of children have. In fact, I received brains of two children who died of these syndromes. And if you look at the MRI scan, what you see is that this area of the brain is called the splenium. And so this area is abnormal. You can see a high signal intensity lesion here on this MRI scan. Now, this particular patient that I've taken from the literature here had fever, rash, vomiting, and then 2 weeks later became encephalopathic, had difficulty swallowing, speech was impaired, and became weak all over. Right? When they looked at the blood, a lot of markers were elevated, suggesting there was a lot of inflammation in this patient. Now, this patient was treated with corticosteroids. So these are not the kind of steroids that athletes take. They're very different kinds of, these are very different steroids called corticosteroids, and intravenous immunoglobulin, and showed a partial response. Okay. So I think this is important to remember because, we have a lot of children now going back to school, which they should, but all the same, they are at great risk of developing these very devastating syndromes. And the number of hospitalized children is going up right now. Okay, now outside of the brain, the infection can also involve the nerves. And the nerves here are ones that supply the eye and control the eye movement here. They control vision over here. And they can also, these are the nerves that come out of the spinal cord and go into your leg, right? They call it the L5 root here. So they're showing inflammation at these arrows, right? At each place. So they can get really inflamed from the infection and cause impairment. And not only that, even the muscle can get involved. So here, this is a histology of the muscle. These little cobblestone-like appearance are muscle fibers. And then this thing right in the middle where the arrows are, these are inflammatory cells. So there's a lot of inflammation taking place over here. And so these cells are infiltrating the muscle. And again, in this case, the patient was treated with corticosteroids, pretty high dose for 5 days, and showed improvement in 2 weeks. So there can be a delayed improvement. So when you give these kinds of corticosteroids, don't always expect they're going to see a miraculous improvement immediately. Sometimes it can be a delayed improvement as well. And occasionally you have to give multiple courses. Okay, now we're going to spend the rest of the time talking about long COVID. Okay. Okay, so one thing to remember is that it can, so this is an interesting study that was from the Dutch and from Netherlands, yeah. And so what they did was they looked at patients who had mild symptoms, moderate symptoms, or severe symptoms. And by mild, what they mean is individuals who developed COVID and stayed at home. They didn't really go to the hospital or anything. Then moderate are those individuals who went to the hospital, got admitted, but were not in the ICU. Severe are those who went to the hospital and ended up in the intensive care unit. Okay. So if you look at on top, you have the severe ones, right? In the middle are moderate and the bottom are mild. So they followed these people along to try and see, how many of them will actually get better over a period of time. And what they found was that if you have severe infection, by 5 months, if you don't get better, you ain't getting better. It just continues. Same was true of the moderate, and the same was true of the mild. So that around this number of 5 months or so, the number of people are continuing to get better. It's not like people don't get better after that. As you can see, these numbers are dropping over here. So some people do get better, but your chances of getting better get pretty dramatically lower. Okay. I've known of someone getting better after 1 year as well. So it can happen, but gets pretty rare. And so what they say is that 50% of the patients with moderate or severe and 20% with mild illness at onset had residual symptoms at 1 year. So now why is it that they have residual symptoms? Are they all the same? And the answer is no. So what I like to do is, so the term long COVID is an interesting term. This was coined by patients themselves. This is not a medical term, but it has stuck. I mean, there are a lot of other medical terms people have thrown around, but none of them are stuck. But this continues to stick. But it is vague because it doesn't really tell you what these patients actually have. All it says is I got COVID and I'm not getting better. That's all it says. But why you're not getting better is not explained by that term. It could be you had some underlying disease that was never diagnosed. Maybe you have, maybe you do have some other known disease that's causing the symptoms. Could be a variety of different reasons. So what I like to do is, if you exclude those individuals who have some kind of other underlying disease to explain their symptoms, you then are left with two types of individuals. One is the individuals who were pretty sick in the beginning. They started getting better, but then some symptoms persisted. They never got better, right? Then there's this other set of individuals, which I think is extremely fascinating. These individuals had pretty mild symptoms. They weren't very sick. They got better, okay, so either completely or close to it. And then few days, weeks, or sometimes even months later, new symptoms arise, and these symptoms plateau, and they don't get better. So in my mind, really, this is the long COVID. And I think these are the ones that we really need to try to understand what the problem is and try to treat them. Not that this is not important, it's just that here it probably is due to end organ damage that occurred early on. They require a different type of treatment. Okay, so as I said, the first set of individuals can also be called post-intensive care syndrome because they were in the ICU. And then there are these other individuals with long COVID. And not all of them are exactly the same. So you can roughly divide them into four different categories, okay? The first is exercise intolerance. So these individuals, they would have some, they never really get better after the infection. And what they complain of is that any bit of exercise and they get really tired. One cardiologist I talked to, she said that she took a flight of stairs, and after that she couldn't even practice telemedicine any longer. Right? She just had to lie down. Some people have difficulty with their sleep, and they can't sleep very well at night. Others can get depressed for the first time. So I know of an individual who worked at NIH, and he told me that he had no reason to be depressed. And he said ever since COVID, he got so depressed he was afraid he was going to hurt himself. So he went and got admitted in the hospital. And now he seems fine. There are people who have difficulty remembering things, or multitasking is very difficult. One individual told me that he could remember what he ate for breakfast, but what he couldn't remember is when he ate it. Was it this morning? Was it yesterday? Was it a week ago? So it's a very strange dissociation of memory just for time, but not for objects. Now our patients have pain syndromes, and burning pain in their hands or legs, headaches, a lot of headaches. And then there are individuals who get palpitations, or every time they stand up, they can get dizzy. One neurologist who got infected with the virus, she was saying that she couldn't even sit up in bed to talk to me. She had to lie down with her phone in order to talk. She would get dizzy. Okay, now this is an interesting study where this comes out of the United Kingdom, and they compared patients with other respiratory infections than those who had COVID, okay, and followed them for 200 days here. And they're a large sample size, 230,000, and that's because they have a National Health Service, so they have records on very large populations. So what they found was that the top line is for those individuals who had COVID, and you can see that over a period of time, more individuals had symptoms of dementia, and more of them had mood, anxiety, or psychotic disorder as well, compared to individuals with other respiratory infections, suggesting there's something unique about COVID that is causing these kinds of manifestations. Okay, so the next thing is long COVID a new disease? Have you ever seen it before? And there are some unique features, but actually it resembles a lot like myalgic encephalomyelitis, chronic fatigue syndrome, Gulf War illness, or the post-Lyme syndrome. So they all overlap with one another to a large degree. Okay, so it's quite possible that a lot of these agents or infections can just trigger in some susceptible individuals trigger a set of immune reactions or what have you that cause the manifestation of these things. And so I think long COVID represents an opportunity to find what those events really are, because if one could do so, you could block it, and you may actually impact all these other diseases too. So I think these diseases have evaded us for a very long period of time. Nobody knows really how to study them, but maybe long COVID would be an opportunity. So we looked at a number of patients we brought to NIH who had long COVID. And what we found was that now we have a biased population, we have neurologists, so people come with neurological complications. But 100% of them have cognitive problems and fatigue. But what is fascinating to me is that this gray area is because these individuals came after so many weeks after the onset of infection. So that's when they develop these neurological complications. So that tells you that there can be a gap or a delay between the infection and the development of neurological symptoms. This paper says that there are some individuals who can develop this restless leg syndrome. I think this is quite interesting because it'll keep people awake at night, but often it's associated with iron deficiency. So somebody has that, people will treat them with either oral iron. Occasionally, some people require intravenous iron in order to treat it. I'm going to skip this. Now, this is an interesting study, again, came from the United Kingdom. And what they were doing is they were doing MRI scans on patients and before COVID. And they had a large population and they would get serial MRI scans. Now, when COVID came, a number of them got COVID. So they kept doing the MRI scans. And what they found was that they had now two populations, one that did not develop COVID and the red line, the ones that did develop COVID. At the bottom is the age of these individuals. And they measured the total volume of the brain. And what they found was that the volume was much lower in individuals who had COVID compared to those that did not. And they found that the older the individual, the smaller the brain. Okay. And so the effects of COVID are much greater in older individuals compared to the younger individuals. And they also found that, so this is trail B as a cognitive task. And the higher the numbers means the worse they're doing. So again, by age, these individuals who had COVID were cognitively impaired as well. So the brains are smaller and they're getting cognitively impaired. So the bottom line is that no matter what you do, don't get old. Okay, so now the next question is that, is the virus in the brain? I mean, that's what we thought it should be. And the reason we thought it should be is because you have all this infection on the nose, and there's a very thin bone that separates the brain from the nose. And this plate is called cribriform plate because it has lots of little holes in it. And through these holes, there are nerves going in and out. Okay. So everybody thought, okay, you have infection of the nose, the virus can go up over here and affect the brain. Turns out not to be the case. The infection doesn't affect the nerve, it affects all these cells around the nerve. And so then it causes swelling and it can compromise the function of the nerve and you can lose smell that way, but the virus never enters the nerve itself. And in fact, here you can see all these black dots are really the virus, and this is the nasal mucosa. You can see all these viral particles here, right? And in this study from Germany, what they did was they looked at the tissues. Again, this is within the nose, this is within the brain. And what they found is that very rarely can you detect small amounts of virus. This is a log scale. And so, but if you enter the brain, even right above the cribriform plate, you can't find the virus. Right? All the virus is in the nose. So as I told you, when we had these brain tissues, we went looking for the virus, we didn't find it. But what we did find was, so this is again, we took an MRI scan of the brain stem here, and we stained it. This brown staining is for a protein called fibrinogen. Okay. And so from these blood vessels, you can see this dark stuff here. There's fibrinogen leaking from the blood vessels and also in the olfactory bulb. And in these blood vessels, we found these small platelets that were sticking to them. And that's how they were occluding these blood vessels. That's how it's causing all these clots. Okay. So there's something abnormal about the endothelial cells as to why these platelets are sticking there. And what we found was that these endothelial cells express this molecule called PKM1. And this is a very sticky molecule. And we think this is being expressed because antibodies are binding to it. Okay. And that's what is really doing that. And once it gets activated, then a number of things can happen. So the platelets can stick and cause clots, or the blood vessels themselves can get leaky and things can go through them. And when they go through, then these inflammatory cells come in, these macrophages, they enter the brain because they're going in there to clean up the mess. The problem is they are really bad guests. When they go in, they never leave. And they keep destroying the tissue around them. Okay. So causes this chronic inflammation. I think some of the long COVID symptoms are probably related to this stuff. So we looked at the neurons again in the brainstem. Here is an MRI image. And we went looking after all these nuclei. And we found that in a number of these nuclei, and I was particularly looking for this pre-Bartzinger complex. I was very keen on this area here. And that is because this controls respiration. Okay. So the ability to breathe is controlled by this. And what we found was that there were these neurons here that looked dead, and you have these activated macrophages around them, all these brown cells around them. So that phenomenon is called neuronophagia. These activated microglia are actually killing these neurons. So I told you that some of these patients had died suddenly, right? A number of them were found dead in their at home. Some were found dead on the subway in New York. And that's how they ended up in the medical examiner's office. And so I suspect that some of them may have had Ondine's curse with sudden death due to involvement of the pre-Bartzinger complex. Okay, can't prove it, but I suspect that may have been the case. The other concern is that, can these patients long-term, what's going to happen to them? What we are worried is that, is it possible that people can develop more Alzheimer's or Parkinson's and the like? And this study shows that this particular protein called A beta 2, if it accumulates in the brain, and it's a hallmark of Alzheimer's disease, you won't find it in the spinal fluid. And the levels in the spinal fluid are decreased. All these red ones are patients with COVID, and you can see these levels are much lower than the controls, suggesting that this protein is getting accumulated in the brain. And I think that is bad news. And in this study done in monkeys, what they found was that there is a accumulation of this protein called synuclein in monkeys who are infected with SARS-CoV-2. And that is also of concern because that is something that can cause Parkinson's disease. Okay. Not that we can say that any patients with COVID are developing it, but there's concern about that possibility. Skip this. Let's skip this one too. Okay, so our hypothesis then is that the antibodies attack these blood vessels. These cells come in over here, the macrophages. You get leakage of these proteins into the parenchyma, and all these cells come in to clean it up. They get activated. They ultimately kill the neuron and form blood clots over here. Okay. We don't have any good animal models. I think that's a big problem. So they're generally disappointing. They have very mild infections. And for some animals, we just don't have any tools to study them. So we really need new animals to study the effects on the brain. So what are we going to do in the future? I think what we need is these patients who are coming to physicians' clinics and complaining of a lot of things, and the physician doesn't know what to do, how to determine whether something is wrong or not. They need new biomarkers. And I think that we need to develop new biomarkers that are for neuronal injury, for blood vessel injury, and for immune activation. And so here are certain things that are still research tools, but I think hopefully effort can be put into trying to make them widely available. And then we need to do clinical trials. I don't think we should wait to study pathogenesis of the disease. I think we should simultaneously do clinical trials because we have too many people suffering from these diseases. I'm not going to go through these things, but just to give you an idea that if you're going to go with immunotherapies, we have a huge number of drugs that are available that target different parts of the immune system. So if you knew what part of the immune system was activated, we have a lot of things that we can do to treat it accordingly. Okay. Our biggest challenge is that we have subjective endpoints. That means patients complain of things, physician doesn't find anything, and the natural history is not. If anyone is interested in participating in any of our clinical studies, here's our email address, and our research team will and then determine if you're eligible for our study or not. So you're welcome to email this. So I want to conclude by saying the SARS-CoV-2 affects the brain in all stages of illness. Long-term complications are variable. Concerns are being raised about the possibility of Alzheimer's, Parkinson's, and other diseases in these patients. Early intervention studies are needed.